All right, I think we'll get going. It's a pretty exciting moment. I think for the department and the division and our mighty colorectal surgery group as well. Oh, Dr. Lieberman says there's 2 links for the meeting. So actually, maybe we'll take 1 second to try to figure that out. So Domenica, if there might be a bunch of people, which makes sense, in another Zoom, another link.
Why, really?
Well, that's what Dr. Lieberman just texted me and said there's 2 different links for the meeting. He was in the other one before.
Okay, I'll resend it to them.
Yeah, let's send out the link again. I thought like multimedia problems were only when we were actually in live, when we would at least take these first 10 minutes to try to say, oh, well, they don't hear us at the Vic, or oh no, they don't see us at the, no, it's still look. Okay. So it's a great pleasure after a few years of organizing and attempts to get this inaugural Labow visiting professorship off the ground. It's certainly a great pleasure, and Dr. Fada, our division chief, has allowed me the honor of introducing this professorship and introducing Dr. Sylla as well. And just a bit of background. So this is a brand new visiting professorship, which is such a great resource for the Division of General Surgery at McGill, gifted by Dr. Samuel Labow, who's with us today. And you can see him there in his, looks like living room in Stowe, Vermont, if I'm not mistaken. And Dr. Labow is a colorectal surgeon in Stowe, who is a proud McGill graduate, both his undergraduate and his medical degree, which he received in 1962. And Dr. Labow was a colorectal surgeon, and he was actually president of the American Society of Colon and Rectal Surgeons from 1993 to 1994. And actually was followed in that role by our own Dr. Phil Gordon, the late Dr. Phil Gordon, a huge giant at McGill and pioneer in the specialty. And this lectureship in general surgery was established in 2019 by Dr. Labow as a gift to his alma mater. And we certainly thank him for his extraordinary generosity and an endowment to ensure the sustainability and perpetuity of this professorship and opportunity for us to interact in this extremely meaningful way with internationally recognized, internationally renowned surgeons, and our, actually Dr. Fada went through Dr. Labow's CV and information at the ASCRS. They have the presidential addresses and messages from all the past presidents. And in Dr. Labow's address, he noted that it wasn't too long ago, there are almost no colon and rectal surgeons in full-time academic practice, but our presence in these positions has grown enormously. And certainly Dr. Gordon as well, I think was one of the trailblazers there, at least in Canada. So I think it's very fitting that we welcome Dr. Pat Sylla to give the inaugural lectureship. She certainly is a trailblazer in colorectal surgery, a clinical innovator, as you will see. And I'm going to just give you a little bit of information about Dr. Sylla. I'm sure it will probably make her blush a little bit, but I just want to make sure everybody knows Dr. Sylla a little bit. So Dr. Sylla received her MD degree from Cornell Medical College, and then general surgery residency at Columbia, and then trained in colorectal surgery, where she is now at Mount Sinai Hospital, and then went to MIS fellowship, or Advanced Laparoscopic Surgery Fellowship, with David Ratner, who we've also had the pleasure of hosting as visiting professorship in our MIS visiting, as our MIS visiting professor a few years back. And that was at the other MGH, the Massachusetts General Hospital. where Dr. Sylla also after fellowship worked and began her career for the first initial part of her career, about I think 7 years. And during her fellowship, so this is what I think is really a great message for our fellows and our residents, is that during fellowship, her research was around, well, Dr. Ratner also was very interested in notes, and Dr. Sylla initiated a transanal notes project in a swine model, which I actually remember seeing a video that she presented at the SSAT somewhere around that time, and being in the audience. I don't know, you see a lot of videos and presentation, but for science, I didn't know Dr. Sylla at that point in any way, but I remember saying to myself, oh my goodness, this is something to keep an eye on. Of course, this is totally insane, but this person is someone to keep an eye on for sure. And while in faculty at the MGH, she further developed her notes work in cadaveric models, and in 2009, in collaboration with Dr. Lacey and colleagues in Spain, performed the first clinical case of transanal total mesorectal excision, TATME, for rectal cancer. And I think we might, our group, our residents might take that procedure a little bit for granted as something that's really found its place in the armamentarium of surgical approaches to rectal cancer. And that's thanks to all the work, evaluation work, research that Dr. Sylla was a pioneer. She's received many accolades, including Young Invest Research Award from SAGES and from the SLS. And since 2015, she's been at Mount Sinai and also very involved in the fellowship program, colorectal surgery fellowship program. And, Dr. Sylla travels the world really now by Zoom, I guess, a little bit, but in person as well. She's a tireless teacher, mentor, leader, and researcher in continuing to evaluate TATME. And one nice thing about seeing Pat on Zoom is getting the chance to see her beautiful family run around, sometimes in the background, maybe not today, and get a glimpse of her kids, Jonah and Ariel, which are easy names for me to remember. And I've had really the immense pleasure and privilege of getting to know Dr. Sylla really a lot better through our roles at SAGES, where she served on the board, and now the exec, where she's currently the vice president and chairing the colorectal task force at SAGES. And I'll just say that, Pat's one of really those people who helps everybody else do the right thing, and a great leader, a mentor and teacher. And I think a wonderful fitting speaker for our inaugural Labow visiting professorship. So Pat, thank you so much for doing this, and I wish we could host you in person and take you out for a great dinner, but we'll have to take a rain check on that, and looking forward to hearing your talk this morning.
Thank you so much, Leanne. It's a true pleasure. And yes, a big regret. We really tried hard to make this work in person, but I know I'll be back at McGill at some point. I have many, many friends. I want to do send a special shout out to Richard and Maria that I continue to torture on various projects, SAGES and otherwise. It's just really been a very close relationship with many of you guys, and I really have enjoyed it over the past couple of years. So it's a real honor to take you through the journey of transanal TME. I think you'll find some really interesting facts and about how we evolved this procedure, from the experimental model all the way to the clinical model. And it's really quite a lesson and quite a journey. And it's not over, unfortunately, but I think it's also a perfect example of how we really harness our global collaborations. And I think this is really an important lesson, that we can't do this by ourselves. We have to really work together to bring these procedures to our patients. So these are my financial disclosures. I have several. None of them are directly related to the content of this talk. However, I am the leading PI of an ongoing North American TATME trial that involves 12 sites, including Canada. These are the sponsors for this trial, which is almost done. We're 95% accrued as of yesterday. So we're really excited to be able to bring those results soon to SAGES. So I'm going to briefly talk about TME. So obviously, I'm sure several of you are not entirely familiar with the concept of rectal cancer surgery. So TME is really the foundation of this talk. And then I'm going to take you back to 2007, which is really the critical year that started it all, and talk to you about notes and how we progressed very cautiously, at least in my opinion, towards transanal TME. And then I'm going to talk about what's happening now. What is the best approach for TME in 2021, which is really no straightforward answer. And then review the outcomes of TME now that we've reached over a decade worth of data. Where do we go from here, especially in light of some of the recent more humbling results, and I'll go through that in detail. So taking you back to total mesorectal excision, really the credit goes to Bill Held. Bill Held is the forefather of TME, and he's really changed the game when it comes to the surgical principles of total mesorectal excision. So back in the 1980s, he was really convinced that the technique of TME, of rectal cancer surgery, had to be improved. There was significant data showing very high rates of local recurrence, and this really was a big problem. You can see here local recurrences at the time were as high as 25% for rectal cancer. And part of the reason that Bill was really focused on was the fact that during rectal cancer resections, the mesorectum, or that the lymphatic envelope around the rectum, was not consistently removed in its entirety. So there was a lot of variability in how much of that mesorectum was being removed. So his concept was you're leaving some tumor cells behind, and this is serving as an implant as a focus of local recurrence. So he essentially worked on his own personal series over a decade where he was in the UK, and was able to demonstrate already some significant decrease in local recurrence rate when he was applying these principles of short dissection of the mesorectum during these resections. And so very quickly, his colleagues and other surgeons in Europe started to pay close attention, and the data started to really speak for itself. As you started to see some series emerge showing significant reduction in local recurrence when they were prospectively looking at their data on rectal cancer resections. This was really a match for stage. So this was the beginning phase of neoadjuvant therapy. So a lot of protocols being introduced of short course, long course radiation and chemotherapy were also being added. But there was no question that by itself, this is the Norwegian rectal cancer audit from 2002, showing that the local recurrence rate was starting to really come down significantly when they applied this training program, this rectal cancer technique, TME, for their procedures. And I want to point out the fact that they really did this in a very cautious and organized fashion. They really had training courses. They were also organizing courses to go over TME principles. So I wanted to really emphasize the fact that this training program was intense and careful and standardized. And so this really was happening in the background of implementing it systematically across their hospitals when they were applying this technique. So you can see again the TME, the data from Norwegian trials showing again a significant reduction in local recurrence rate, down to 6% compared to non-TME, 12% rates, with also you starting to see some improvement in overall survival in these cohorts as well. So the Dutch followed along as well around the same time, also implementing systematic TME for their procedures. They also had that neoadjuvant short course radiation going at the same time, but regardless, they were seeing some significant improvement in local recurrence rates in their own cohorts. And same thing, they were really applying very strict quality control in terms of the technique, really training their surgeons in the proper technique. And this was also happening with some standardized way of examining the TME specimen. So Quirk and all were already working on the process of examining the TME specimen, implementing standards in terms of pathological assessment of the integrity of the mesorectum for these dissections. So, and other important trials that we all talk about, obviously this is our legacy, this is Bill's legacy, the German rectal cancer trial from 2004, also implementing standardized TME surgery. And you can see, although those patients were also starting to receive chemoradiation therapy, even independently of that additional chemoradiation therapy, you could see significant decrease in local recurrence rates, not in survival, but in local recurrence rates in combination with chemoradiation therapy. So the bottom line is, you're starting to see now a significant, across the board around the world, an impact of good quality TME on local rectal cancer outcomes. So local recurrence rates went from the 20s to 25% range, all the way down to 10% and even lower than 10% in the setting of this innovation. So the bottom line is, what is optimizing? How do you optimize TME? It has become the gold standard approach for curative rectal cancer resection since the 1980s, really implemented worldwide. And the concept is really good quality surgery. You want to achieve a negative, what we call a circumferential radial margin, the distance between the tumor and the edge of the mesorectum, and you want a good quality specimen. What does that look like? This is what our pathologists have to assess on a fresh specimen that we deliver from the operating room. Even before processing it histologically to assess the margins, they are going to photograph the specimens front and side, really confirm that the mesorectum is intact. This is a near complete mesorectum, not complete where you actually have some shallow superficial defects in the mesorectum. The good news is that you don't have exposed a bowel wall, which is really what you don't want, because that tells you that you've left some mesorectum behind in the pelvis that could potentially serve as a focus for a local recurrence. So this is a target. You want to achieve a complete or near complete mesorectal excision, which sounds straightforward in theory, but is really can be quite challenging to accomplish. And we'll talk about the technical issues. So this is what our pathologists do now in the lab. This is a critical part of assessment of the TME quality, assessing the specimen, slicing it, and evaluating that CRM, which is, again, we're looking at the edge between the tumor and the distance between the tumor and the edge of the mesorectum, which really is an independent prognostic indicator and predictor of local recurrence. So this is what they're looking at. There's different patterns of involvement of the CRM, and this is what they're going to be telling us and will help predict the risk of local recurrence in our patients. So optimizing rectal cancer outcomes has been a big focus over the past 2 decades. So it's not just the oncologic resection and the TME quality, of course, but we also are looking at performing these procedures and reduce morbidity of these procedures, which was quite significant. We'll talk about that as well. But the cornerstone is proper preoperative staging, which is really critical, implementing neoadjuvant therapy protocols, which we know have a significant impact on tumor response. We talked about the oncologic resection. That's our part. This is a surgical issue. And then the pathological assessment by our colleagues. And very important to be able to predict the resectability of those tumors, be prepared. So you don't go to the operating room blind. You need to know exactly where the tumor is, how it involves, whether it threatens the sphincter muscles. And these are very important considerations before surgery so that you can perform the best procedure possible. So ultimately, it's a multidisciplinary team sport. You really have to work very closely with your radiology colleagues, oncology colleagues, radiation oncology, and your pathologist to be able to really provide the best care possible. So this has really been demonstrated time and again that participating in an MDT or tumor board, evaluating those tumors before chemoradiation, after chemoradiation, before surgery to really assess the actual stage of the tumor and plan your surgery better is associated with an improvement in the quality of your resection and decrease in a chance of positive, what we call the CRM, circumferential radial margin. What about sphincter preservation? Now, you know the principles of rectal resection, but ultimately, you know the big threat to patients is when you tell them there's a risk they might actually lose their continence and you have to remove their anus in continuity with the rectum. Very devastating to patients. This is the big issue with rectal cancer surgery. And so there's been significant evolution, especially in combination with chemoradiation therapy. Now we're moving increasingly more and more towards what we call TNT, or consolidated chemotherapy and radiation protocol, where you do all the chemotherapy up front. And then so that the patient receives everything before and then pretty much nothing after surgery. And the idea is that you can increase the response rate of the tumor and even achieve potential complete regression of those tumors. But even by itself, chemoradiation therapy has had a big impact on downstaging tumors to the point where you can actually safely do a resection as low as within 5 millimeters of the tumor. So that really makes a big impact in terms of how low you can go and still preserve a little bit of the anal canal to be able to reconstruct patients and restore their continence. And this is a big deal. It's been this combination of chemoradiation therapy protocols has allowed us to actually consider safely offering patients a sphincter sparing, including with partial or complete sphincter resection, and I mean specifically the resection of the internal anal sphincter. So this is what it looks like. This has been pretty well outlined well over a decade ago. We have long-term oncologic results that really support this approach. Again, very carefully with your radiation oncologist, and your radiologist, you want to review where the tumors are specifically. So by MRI, and by digital rectal examination, the tumor is well above the anal sphincter. You don't have to really worry about your sphincters. You can essentially come across with your surgical stapler during surgery, either open, laparoscopic, robotic, whichever way, but you can essentially come below the tumor, preserve the anal complex, and then provide reconstruction. But when the tumor starts to threaten the sphincter, so when it's starting to approach the anorectal ring right here, at that point, you have to really consider performing what we call a partial intersphincter resection, if feasible, which is here, you're essentially removing and here the part of the internal sphincter muscle to achieve a negative margin, but you're still able to reconstruct the patients because you're leaving a little bit of the internal sphincter muscle and you're leaving all of the external sphincter. Technically challenging, but feasible, and with some good oncologic data. The complete ISR is for patients who have actually involved internal sphincter muscle. And so in this particular case, you can restore continuity, but obviously it's the issue of continence. But you can still do it and provide a complete intersphincter resection, remove the entire sphincter in continuity with the tumor and their TME plane, and leave the external sphincter muscle. Terrible continence, but many patients would rather have this option than having an APR. So we do offer them if it's deemed to be oncologically safe at MDT. And then, of course, when the tumor involves the external sphincter muscle, at that point, there's really not much you can do. And so, unfortunately, especially they have not responded to chemoradiation therapy, this is essential to provide an APR because you need to be outside of that plane of dissection to be able to provide a negative margin. So how do we make those decisions? These are very important decisions and very difficult decisions. Again, MDT review, because when you actually look at the MRI together before chemoradiation therapy and after, you really can assess very specifically the relationship of the tumor to the sphincter muscle and be able to make that decision. And using MDT, and I'm sure you experienced this, you can change the operative plan, within literally a few minutes of reviewing the studies together. And occasionally it changes your operative plan altogether because your radiologist will help you navigate through those difficult planes and really make the best plan based on what the perception of threatened margins is. So now you pretty much are an expert in TME and rectal cancer, the principles, the rationale, the results of conventional open surgery. I'm going to take you back to 2007. Okay, this is really the critical year when it comes to transanal TME. So I know many millennials have no idea what Back to the Future is or who Michael J. Fox is, but for those of us, this is sort of a similar sort of deja vu. But in 2007, where were we in terms of rectal cancer is really quite interesting. We were still very much in the open TME realm. There are really no strict operative standards for TME. The TME protocols that I talked about, the pathology protocols, were not implemented widely by pathologists, at least not in the United States. And quite honestly, the majority of rectal cancer surgery were performed by low volume surgeons. And a large majority of the patients, at least in the US and probably in Canada as well, were essentially committed to an APR for their rectal cancers, especially for mid and low rectal cancers, were systematically taken to the operating room for an APR. Also a very sobering data. This is actually from data from the National Cancer Database reviewing 2010, 2011 data. So that's even later than 2007. So you can imagine the same thing was happening in 2007. But it's really important to show here that the incidence of positive CRM was quite high. So when they looked at that data, and this is audited data from the NCDB, 17% positive circumferential radial margin, which is really quite high. So you can imagine this translates into local recurrence, very significant high risk of local recurrence. And you can see that this correlated with cancer volume. So the volume of surgery was really a predictor of outcomes. And so a very high rate of CRM, even at academic centers, as high as 16%. So definitely not the less than 10% objective that has been outlined and described by Bill Held. Another sobering data set from the 2007 to 2010 era also is showing that when administrative data was reviewed, discharge data from hospitals from over 21 states was reviewed, over 7,000 proctectomies performed between 2002 and 2004. You can see that the large majority, again, 51% of patients were undergoing APRs. Or at least non-restorative procedures. So very few surgeons were actually even trained in performing a sphincter preserving surgery. And they saw that the surgeons who did APRs tended to only do APRs. They were not surgeons who were offering even LARs for those rectal cancers. And you can see the 50% of surgeons who are performing proctectomy were also the lowest volume surgeons. So clearly some issues related to even the chance of patients to be connected with with surgeons who would perform a sphincter salvage. So high CRM rates, high rates of APRs. This really was what was happening in 2007. On the good part, there was a lot of really exciting stuff going on. Collar 2 trial, so the randomized control trial in Europe of laparoscopic versus open low anterior resection was ongoing and actually enrolled and closed in 2010. Robotic surgery was still at its infancy in colorectal surgery. It was quite well established for urology procedures. But actually in 2008, Alessio Pigazzi published the largest series in the US, 39 patients undergoing robotic colorectal surgery. So this was really still very, very early, but promising. And then also very exciting, at least for the TATME world, that was later to come, is the fact that intrasphincter resection, we started to see some series out there showing the oncologic safety of intrasphincter resections for carefully selected low rectal cancers. And this was really critical information to really be able to be sure that this approach, sphincter salvage for the very low cancers, was feasible in selected patients. In 2007 also, we were in the middle of a notes revolution. So this really was quite a surprise. A lot of people were not really aware of what was happening in the world of MIS general surgery. But in 2005, you actually had a unofficial report of a transgastric appendectomy performed in India. And then in the background of a lot of experimental work happening, in 2007, this really made the news, was that the first case of transvaginal gallbladder removal was performed. Actually, there was one performed by Zoran, and not long thereafter, Urquhart also performed their first transvaginal cholecystectomy. So this was really happening in the background of a lot of activity in the lab around the world, in Hopkins, in MGH, at Brigham, a lot of groups combining gastroenterologists and surgeons working together to essentially develop strategies to use primarily endoscopes, colonoscopes, gastroscopes to enter natural orifice cavities. Essentially, the mouth, stomach was a route of access, the vagina. The rectum was not really on the radar until a little later, but this was really happening fervently in multiple labs, outlining the basic principles of performing essentially incision-free surgery, major abdominal procedures through natural orifices using primarily endoscopes and novel equipment. And you can see here some of the experimental data in animal models. Again, 2006 and 2007 was really focused on transgastric approaches, so a little bit of transcolonic work, but not a whole lot. It wasn't until a little later that transcolonic work and transrectal work starting to be explored more actively. And part of the reason that things, with notes kind of slow down a little bit after these first couple of reports of transvaginal cholecystectomy, for example, was the equipment was really not quite there. So we all know that a colonoscope is not designed to perform these procedures. It's obviously not smart engineering, and you need really sophisticated devices to be able to do these complex procedures. So a lot of companies were starting to develop prototypes to perform notes, and many of them did not make it to market for a number of reasons. Too long to describe, but the bottom line is issues with funding, problems with the FDA approval, and there was also a financial crash around that time. So clearly things did not progress as well as we wanted. We were very lucky in the transrectal world that we didn't really need to have a new fancy prototype, retroflexing 3-arm or 4-arm pronged colonoscope. We actually had the TEM platform, which had been introduced by Professor Bruce back in the 1980s, with a lot of experience around the world using this platform. One of those experts in TEM is Mark Whiteford, who was actually working with Lise Holmström in Portland, Oregon, and they were doing quite a bit of notes work around the time. And Mark, who's a colorectal surgeon, actually was not at all interested in gallbladders, and so he was very focused on the colon. So he actually used a TEM platform. This is really the most critical influence in the evolution of TATME was this report. I was very lucky, actually. Dr. Ratner invited me when I was a fellow to attend this notes meeting in Boston. This was the second NOSCAR meeting in Boston, and I happened to be in the audience when Mark presented this paper. And it didn't get a whole lot of attention by the crowd. It was really very much focused on gallbladders. But I think I probably was the only colorectal surgeon in that room, and I can tell you, I knew this was the future of colorectal surgery in many ways. I was lucky to have been trained in TEM when I was a fellow at Mount Sinai. So it didn't really take long for Dr. Ratner and I to conspire to start working on, back in the experimental in the lab, and really think this through in terms of evolving this procedure from the animal model, a cadaver model, and then eventually to patients. So Mark and I became quite close friends. We're very lucky to be able to collaborate with him early as well. We went back to the lab. This is actually the first model using swine cadavers. That's how much I had no funding at the time. So as a fellow, we worked essentially with cadaver carcasses after they were done doing their fancy transesophageal and transgastric work. We used them to essentially demonstrate the feasibility of transrectal dissection of the pig rectosigmoid using a TEM and TEO platform. And then very quickly, this was really the beauty of being in the lab that had resources. We could transition very quickly to a survival swine model. So our team really worked very quickly to try to demonstrate the feasibility of this. We compared it to standard laparoscopic rectosigmoid resection, and the pig's model is not great, as you know, for rectosigmoid and mesorectum. So, we had that proof of concept. We're very pleased with this, but, to be quite honest, we were very focused on actually doing these procedures entirely notes. So we were trying to avoid all incisions at all. So you'll see a lot of the work that Leanne was talking about seeing in conferences was really doing multiple procedures to avoid any abdominal incision. This is in a cadaver model. We're actually doing a transgastric combined with transcolonic with a TM platform, but with a colonoscope through the stomach to essentially do a splenic flexure mobilization here after I've completely mobilized the rectosigmoid in a cadaver. My colleague is going from the stomach, and actually is an expert endoscopist and mobilizing the stomach as well to try to mobilizing splenic flexure. You see the scope here coming from above, trying to see if we could actually do a full mobilization to do a rectosigmoid resection with absolutely no incision. That was the holy grail that we're really trying to prove. And yes, we could do it in a couple of cadavers. The problem is that it would probably take about 15 hours in the lab to do that. But this was the dream. This was a dream, and what we realized obviously very early on was, yes, it is feasible to do this in some cases, but that was not going to be the holy grail. The holy grail was going to be to combine this to really harness the advantage of doing a transanal approach for the distal part of the rectum, and then use your conventional laparoscopic approach to do your proximal mobilization in your splenic flexure. So we were migrating very quickly to a hybrid approach, and showing really the most striking part about this is after over 32 human cadavers, we could show consistently a really good quality TME regardless of cadaver size, sex. We were really quite impressed with the quality that we could achieve and how reproducible this approach was in cadavers. But then that's a lot to say to how do we move on to a patient, especially when you're talking about doing rectal cancer surgery. This really was the big challenge. And again, harnessing your collaborations with your international colleague is key. David Ratner happened to be very good friends with Antonio Lacey. They played many games of golf. And I had no idea. Lacey at the time was, to me, the god of minimally invasive surgery. He was one of the co-authors of the Collar 2 trial. I mean, I couldn't even imagine being in the same room with this person. And Dr. Ratner made the introduction through phone calls, and Lacey essentially within 2 months was able to get IRB approval for performing a first case in a patient. He invited me to come over. At the time, I was actually 7 months pregnant, so it was interesting. It was a tricky operation, but his wife at the time was an OB. So she called me personally and said, "Pat, don't worry. If you're going to preterm labor, don't worry, I got you." So that was enough for me to be convinced to go over there and participate in this really groundbreaking procedure. Equipped with our experience in over 50 cadavers by then, and especially with the expertise of Dr. Lacey, we were able to do this procedure in a patient just like we did so many times before in a cadaver. So there's no question, and having the ability to train in an experimental model before these first cases is really critical. At MGH, however, it took me 9 months to get IRB approval for the first pilot. So it took quite a bit of working the IRB to be able to get that pilot off the ground, but we did it. And the results, as we thought, were quite exciting. And this is really my proudest slide, I think, here is, seeing this and presenting this and talking about this and publishing it quickly, to see other surgeons around the world pick up on this so quickly and really starting to develop this approach using a variety of transanal platform was really the best part. So part of it was excitement to be able to diffuse this and disseminate it, but it was also a little bit of trepidation about the fact that, talking about this procedure, I felt the entire time, wait a second, I did this in 30 cadavers first, okay? So my learning curve was quite long. It probably was 30 cadavers long. And so, you see then surgeons, around the world, very experienced surgeons, but embracing this quickly. A lot of us were concerned about this and really started to think very early about we need to train. We need to focus on training right away because this could get out of hand very quickly. So Around this time, we were part of the reason why TATME started to flourish so quickly also is because besides those rigid platforms that very few sites had, there was the introduction of those transanal minimally invasive platforms, disposable transanal platforms that were essentially recycled from the Sylls era. So you can see in 2010, these platforms make a big difference. And so the way we're using these platforms, as you can see, so for a tumor that we talked about well above the sphincter, you place your platform, you occlude the rectum below your tumor, and then you start your full thickness dissection through the rectal wall to get into the TME plane. So pretty straightforward for your upper, mid tumor, and the ones that are clearly above the sphincter. These are the most straightforward TME cases. However, when you're dealing with the much lower tumors, that are just abutting the sphincter, then this is where you really have to start your dissection in a traditional open with a Lone Star way, starting your intrasphincteric resection to get below the tumor and ensure you have your negative distal and circumferential margin. Then you dissect along the intrasphincteric plane. So this is a principle of the intrasphincteric resection I was telling you about, partial intrasphincteric resection, and then you place your platform after you occlude the rectum, and that's when you start doing your TATME, so your TME dissection from the bottom up, using your abdominal approach as a hybrid to assist you with IMA dissection, IMV, spinal flexion, and all these other steps that are critical for TME. So this is what, for those of you who haven't seen this, I know you're doing this routinely at McGill, so I'm not going to spend too much time on those straightforward cases, but you can see here the same principle. You're going through the full thickness of the rectal wall, and you can see pretty quickly here, you start finding the bottom of the mesorectum. This is the most satisfying part because, you know, this is the hardest part when you're doing a laparoscopic or robotic case, is to get all the way down below to the pelvic floor to make sure that you've essentially reached the end of the mesorectum, that tapering end of the mesorectum on the anal canal. So here with the transanal approach, you can see the levator here, that muscular V shape, you know, especially in the male, very tight space. And as opposed to from above, where you're really struggling to try to get down to that level, from the bottom up, you actually see everything in line with your scope. You can see this is the back of the prostate. You found the anterior TME plane beautifully. You have complete control of your mesorectum. There's really very little need for specimen pulling, tugging, you know, all that kind of maneuvering that happens during abdominal laparoscopic, at least laparoscopic TME. Very nice, elegant dissection. The key again is a beautiful view of the anatomy once you've understood your landmarks. And you can see here, the hybrid approach is critical. You can see here, the abdominal surgeon is coming along, and you can actually work together to join those planes and really ensure that you have the best exposure possible to ensure that you have that most perfect specimen, because you've taken all the mesorectum away and there's no risk of a defect. And you can see here, we're extracting here. This is a very bulky specimen. So we're extracting here through a fine and Sylla incision, and you can see the quality of the mesorectal dissection is excellent. Here, my colleague is palpating a node that is filling in the mesorectum, but you can see here, this is the goal. This is what we set out to do. And then we'll talk about the anastomosis in a bit. So now for the tricky ones, so the ones that are lower down, this is where it gets a little more tricky. And this is where the training is really essential, especially in surgeons who have not trained classically in the intrasphincteric resection. We recommend doing this part open, because endoscopically you can get quite lost in a tissue plane. But here you can see this is a little bit more tricky because you're actually low down, that you actually have the muscular planes is a little more tricky to identify the levators. So very important to be able to find yourself. So we recommend for surgeons early in the learning curve to actually do this part because you have to resect some of the upper portion of the intrasphincteric muscle has to be resected before you can see here, the bottom of the mesorectum is coming into view. So that entire dissection here was part of the intrasphincteric, the internal anal sphincter muscle was taken before you can actually expose the bottom of the mesorectum here. So the key is you really have to be familiar with this anatomy from the bottom. This is an unusual anatomy for those who've trained from the top. So there's clearly a learning curve. You have to get comfortable with the anatomy, especially the high risk areas, the neurovascular bundle here anterolaterally. If you don't recognize it, it can definitely bleed. So if you're too lateral, you can get into the pelvic nerve plexus, and that can be associated with pelvic floor dysfunction, sexual urinary dysfunctions. You have to be very careful. So there's quite a learning curve to really be familiar with this anatomy from the bottom. You don't usually see the neurovascular bundle from the abdominal perspective. So this is why it's really important to get familiar. So I showed you the data early 2010, and you can see within 5 years how quickly the procedure is starting to be evaluated. So you can see short series, but starting to get larger and larger around the world. Very exciting work. And this is a key work really to assess whether or not the procedure is reproducible. and safe and feasible, and what the early experience is in terms of complications. So you can see the big advantage of TATME is that you can combine it with any devices that you want. You have, a lot of options in terms of devices, approach, hybrid, how much hybrid you do, how much abdominal you do, how much transanal you do. There's really no strict rules. And so that's the beautiful thing of this, is you can see, various strategies, but it also makes it more, a little more complicated in terms of delineating clear operative standards. And we worked very hard on that, but the bottom line is there's multiple ways to do things. And so it creates a little bit of a difficulty at the beginning when you're trying to standardize procedures, obviously. So the best event after this, I think, was putting together the International Rectal TATME Registry. This was really an important event. And this really allowed us to start monitoring results very closely. And then training, obviously, was the essential part. And I mentioned training. Training was a tricky part. In the US, we were very alert to this. So after describing the first procedures and really recommending a cadaver training, so the 2012 message at the ESCRS, this was presented at the ESCRS, was to say, we can do these procedures, but we really recommend training first in a cadaver. For our first case at MGH, we had actually done a team rehearsal of this procedure in a cadaver 2 days before the procedure. And that team training was really critical to get, to get this procedure done in a safe, coordinated fashion with the entire members of the team, especially because it was a 2-team approach, 2 laparoscopic setups, 2 operative surgeons and their teams. So this was really tricky to organize. So we really recommended this team approach, team training approach to do these procedures. And shortly thereafter, Lisa Malcolmore delineated the first paper with the training pathway, again, emphasizing the importance of training in the lab before. We also organized our first US surgeon training lab that was sponsored by industry. And again, we had the luxury of being able to work with cadavers, which obviously is the best model because you can actually evaluate the quality of your TME after this procedure and get feedback from your proctors. But this was a really turning point. You can see a lot of surgeons in this room. You can see here Peter Marcello, Mark Whiteford is here, Dana Sands. We have a lot of our surgeons who are in this room are surgeons who are really the leaders of TATME in the US and are actively participating in our TATME North American phase 2 trial. So very important to have selected high volume surgeons, experienced surgeons who we knew were going to be implementing this using the recommended training pathway. We looked at this very carefully, trying to monitor the experience of the surgeons after their training. And this really helped us delineate the first training pathway that we really were recommending, again, with this really foundation of expertise in laparoscopic or robotic TME, expertise in transanal surgery, and especially experience in intrasphincteric resection. But also the cadaver model, very important. Proctorship was starting to be really advocated because we recognized that no one has a luxury of doing 30 cadavers like I did before implementing these procedures. So this is the international registry I was telling you about. We were very lucky to have Roel Humps from the UK, who was really actively engaged with Marta Pena in developing this TATME registry. So we could really very early on start collecting a large volume of data and monitor outcomes. This is real world data. Obviously, this is not validated with audits like other type of data, but this was really helpful to keep our fingers on the pulse of what was happening around the world, especially in places where we could not control whether or not surgeons were training appropriately. Speaking of which, we started to pick up on some stuff. Okay, so with new procedures come new complications, and TATME was definitely not immune to that. So the ones we really were most focused on was the event of urethral injury and leaks. Leaks really had to do with this technique of how you put the bowel back together when you don't have a stipple line, like in your regular LAR. And so we had to do a lot of work to really figure out the best approach when you have an open rectal stump, from placing a purse string suture, then place a drain to be able to connect your end vole on your proximal colon down there, incorporating ICG or not, strategies to really reduce the chance of tension. So all these tricks, and these are all tricks, require, there's a significant learning curve with relearning to reconnect the bowel when you have an open rectal stump. So if you can't hand sew because you're not that low, you have to be able to do a purse string suture. And that sounds nice, but in the US at least, colorectal surgeons don't do a whole lot of suturing. And so, except for intracorporeal suturing or rectopexy, most colorectal surgeons don't suture very much. So we had a lot of learning to do in the lab to get comfortable with transanal suturing through transanal endoscopic platforms. So there was a significant learning curve with doing that safely. So, but I think overall, surgeons were able to overcome that hurdle with adequate training. Urethral injury was tricky. We had heard about the first report of urethral injury during TATME back in 2013. Then we started to get some reports coming in, few cases around the world. Our colleagues were very good about publishing of this and reporting this, so the word was out. But, what was more intriguing about this was, and Sam Atala from Orlando demonstrated this, that, even in trainees who had completed, their structured training, had done cadaver work, had done all the work, still had urethral injuries despite the cadaver training. So that really raised the alert of what is going on, why is this happening? This is a video that I showed at ASCRS in 2015. This is a complication. This was my first urethral injury as a TATME surgeon back at MGH. This was quite traumatic because I felt that I had really mastered the technique quite well. And you can see here, I mean, this is a video that I've watched probably hundreds of times by myself, with colleagues, reviewing it with experts, to really start to understand how things went wrong. You can see we started the dissection here. And in retrospect, it took me probably 2 years to really understand where things went wrong with this procedure, is to understand the concept of the rectal urethral muscle. You can see here, right here, at the time, I did not even recognize this was a real thing. But it is actually a warning sign that if you don't recognize it and stay below the prostate, if you go too high and you don't recognize this is a rectal urethral muscle here, the plane should have been here, the dissection. I am too high by about 1.5 centimeters to 2 centimeters. I'm going to essentially be heading straight towards the prostate in a second. I don't recognize that the plane should be right here. I'm way too high. There's some bleeding there. I don't recognize it. I switched from cautery to a bipolar device, big mistake as well. See, the plane should be here. I'm dropping the prostate without realizing it. I'm way too high. And then next thing you know, I get into the urethra, right there. And you can see me pausing, because even after 30 cadavers, I can tell you I had never trained myself to do that before. So this was a very unexpected complication that I myself had experienced, but then we started to see some reports out there of this problem. So this was a perfect example of when something like this happens, you have to go back to the drawing board and really go and understand how this happened. And that's exactly what we did. Went back to the drawing board. We actually understood the concept of the rectal urethral muscle better. There was this approach called radical perineal prostatectomy back in 1904 that actually described performing a perineal prostatectomy and identifying the rectal urethral muscle at the time, a structure that we really were not trained to recognize as colorectal surgeon. Even during APR, no one really talked about the rectal urethral muscle. So rereading this anatomy from back then, understanding the anatomy a little bit better, and understanding that this rectal urethral muscle essentially connects the anterior rectal wall to the urethral sphincter. And this is actually a muscle you have to divide when you're very low. You have to divide it to get into the right plane between the prostate and the rectum. So we had to essentially relearn this, understand it, and then this really allowed us to really understand the mechanism of this injury. So we collaborated again internationally to really understand this injury, collect all information about all the cases that we knew about. So we had 34 cases around the world, as well as 3 bladder injuries and 2 urethral injuries during transanal dissection. And with this, pulling all our data together, we're able to really start to understand that this is primarily a learning curve issue, that the majority of those cases are happening early during our learning curve. And so this was really an opportunity for us to be cognizant of this, go back to the training models. And you can see here, this is what the dissection should look like when you're very low. You've done your intrasphincter resection and you get into the proper plane. You have to divide the rectal urethral muscle just right here. But if you're wrong, if you're in the wrong plane and you go too high and you miss the fact that the rectal urethral muscle should be cut right low, close to the rectum, and you go too high, this is where you can put the urethra at risk. So understanding that and understanding the anatomy, refining the anatomic landmarks was very critical to be able to move things forward. This is a typical example really quickly. You can see we're very low. We've done intrasphincter resection open. We're closing the anal rectal stump, and I'll show you in a second what that rectal urethral muscle looks like. You can see here we're quite low, and this is where the muscle starts to come into view. So now we recognize it. You see the back of the prostate. by dividing this muscle at the proper level, not up here. This is where it was, a couple of years before. You need to be really close to the anterior rectal wall and really dissect this rectourethral muscle to get to the back of the prostate. And only then you know that you essentially are in the correct plane. And you can see here, we're back on track. And then the posterior dissection clearly is what we know it to be. You can see a very tight V-shape levator, very tight space. And again, you're harnessing the strength and the power of this approach. So we went back to the training model, incorporated all that information and really refined the training model. But ultimately, it comes down to the learning curve. And your very own Larry Lee has done a lot of work to define the learning curve, and it's not pretty. The learning curve is anywhere between 45 and 50 cases, if not more. This is still in the hands of experts. And so other publications have confirmed that. It takes a long time, as you've seen, and it takes a lot of expertise in transanal work to be able to perform this procedure. So a lot of surgeons around the world started to put together proctorship training, other training initiatives to try to see if we could shorten that learning curve, knowing that no one had the luxury of doing 51 cases before, because that volume is just so high, and that very few cases, very few centers will be able to provide that learning experience for their surgeons at any given institution. So what was the next chapter for TATME? Obviously, randomized trials, right? That's what everybody wants, level 1 evidence. And so as those were building up, we still clearly knew that around the world, TATME was really moving forward. So the bottom line is, taking you to the best approach. We all know the challenges of TME, right? The TME is, you kind of have pretty straightforward TME when you have a pretty wide open pelvis here, but we very well know this is where the difficulty happens, is when you have a very narrow pelvis like this. This is where any abdominal approach of TME, whether you're laparoscopic or robotic, is going to be very challenging. We know the data from the randomized trials comparing laparoscopic to open. We know the rate of CRM positivity was still 12.1, at least in the American trial. The conversion rates is as high as 10 to 17% in the laparoscopic, and that's by experts. And the APR rate in the Collar 2 trial was incredibly high for tumors less than 5 centimeters from the anal verge. So this is really the baseline. In the best hands, laparoscopic TME is very hard. High conversion rate for low tumors, high APR rates for low tumors. So clearly the hope was, can we do better with the robot or TATME? The robot really showed, this is the only properly conducted randomized trials comparing robotic to laparoscopic TME. No significant difference in conversion, unfortunately. No significant difference. The CRM rate was very, very good. You can see only 5.7% positive rate. So clearly very good dissection, very good surgery. But the APR rate was still high, in the upper 20s. In this cohort of patients with tumors less than 5 centimeters from the inner verge, 25%, APR rate. So the robot did not really help with these really low tumors as much as I think we were hoping. But what's really exciting with TATME is now that we have 10 years worth of data, what does the data really look like? I mean, that's a big next question, is what does it look like? So now we have a series now with more than 80 patients, and we have our TATME international registry that I mentioned that has actually now over 2,800 patients, but this is the short-term results. And again, this is probably the most striking part about TATME. If there's anything you're going to remember here, or the big differences that we think there is between TATME and the other approaches, is the conversion rate. These are this is reflecting the learning curve of those surgeons during their series, and you can see conversion rates ranging from 0 to 5.6%. That's in a registry here that only had 1,500 of the 2,800 patients that are already in that registry. Very low conversion rate, remarkable, actually. Morbidity is very similar to what you would expect with abdominal TME, mortality as well. Leak rates, not any lower than any other approach. That's really the weak point of all these anastomoses. As I showed you, the reason why this is happening, leak rates are not expected to be any lower, but they're about the same as what you would expect for an abdominal approach. Oncologic outcomes, obviously all eyes are on oncologic outcomes. The early metrics, so your quality indicators for good quality TME are good. You can see the CRM rate, across the board in all this large series is consistently 10% or less, with the exception of this one study that I'll mention in a little bit. Same thing with the distal rectal margin. Positivity rate is well under 2% in the majority of cases, except with a few exceptions. For the most part, it's quite good. I mentioned the TATME registry. The latest results were published just literally a month ago. 2,800 patients collected, and you can see here CRM rate was 5.1%, so very good. It's equivalent to the ROLAR trial. DRM was only 1%. Again, the quality of the TME, very, very good. And then now, obviously, what we care about now that we're in the longer surveillance mode of long-term data collection, you can see here local recurrence rate, which is really what we're interested in at this point, is very reassuring, except in these two recent studies from the Netherlands and Norway that I'll talk about. But across the board, including in the TATME registry, 4.8%, so 5% or less in a majority of centers around the world for long-term, up to 2 to 3 years. Three plus years now, local recurrence rate, but unfortunately, we can see here some red flags here coming from these these two sites. So, just to focus on this is really essentially the Norway data that I'm sure you've heard about. So this audit of rectal cancer outcomes. TATME results, 157 cases, they identified a 7.9% incidence of local recurrence, which is higher than what you would want. 12.7% positive margin rate. So this local recurrence rate was deemed obviously too high compared to what you would expect in a national control cohort. So this has raised the alarm of why this is happening. Not only this, but these recurrences were actually noted to be quite nasty, what we call multifocal pelvic side wall recurrences. That we're kind of figuring out what happened in this particular series. This is another a study that came from the Netherlands, where they essentially looked at the first 10 cases performed by surgeons who had just been trained by a proctor in doing their first couple of cases, and then they went on to do their first 10 cases. They looked across 12 hospitals and audited the results. Same thing, they found an unusually high rate of recurrences, 10%. But also, not just that, they saw a very high leak rate. So clearly a lot of technical issues with these cases, which contributed to this incidence of multifocal recurrences, but clearly something that we're all paying close attention to, because clearly this is so concerning that Norway has put a hold on TATME and the training pathways in some parts of Europe have halted, because the more information needs to be obtained to really understand how this happens. Now, we know the learning curve probably has a lot to do with this. This is a really elegant study looking at all sites doing more than 41 TATME cases. And you can see here there's clearly a correlation between the local recurrence rate and the case volume. So you're early in your experience, you can expect a higher local recurrence rates. You're more experienced, so you do more and more cases, your local recurrence rate is going to drop. This obviously makes intuitive sense. I'm sure the same learning curve was applicable to laparoscopic or even robotic. The only difference here is that we actually, for TATME, we've been looking very closely. You will not find a study of robotic TME looking very closely at surgeons' performance and outcomes, over the first 10 cases and then ultimately the first 40 cases. So I think by virtue of being so attentive to our results and so focused on our early learning curve experience, I think you're uncovering some of these effects of the learning curve on recurrence. So where do we go from here? I think, we know that a lot of TATME adopters did not follow the recommended training. So this is clearly adding to the mix. We know a lot of surgeons are not telling their patients, or not performing these procedures on IRB protocol, or not telling them about those risks. And that's something that, we have to contend with. So we're still recommending the same pathway. The societies are obviously want us to be more rigorous and be focused on registries and audits. And I would like to remind them of the fact that, Leanne participated in this incredible ideal framework, which has become our Bible when it comes to surgical innovation, and really demonstrating and showing the importance of progressing from, experimental phase and your first clinical case, and going very carefully through multiple study designs to be able to demonstrate the safety of precision. We've done that. And I think it's important to remember that these ideal recommendations, which were published in Lancet in 2009, are still very applicable and very much apply to TATME. As a matter of fact, they apply so well that, Roll published this a couple of years ago to show, without even realizing it, because ideal framework was unpublished when we started TATME, but we pretty much followed that exact pathway. We've been incredibly meticulous and careful, as you saw, transitioning through all those phases, collecting data carefully, and this is where we are. We are at the phase of long-term surveillance, where now the pool of surgeons around the world are publishing their long-term data, and we're starting to see some events, some issues with learning curve, some issues with training. We haven't been able to standardize or convince surgeons to follow the training pathway, and this is starting to get reflected in some of those long-term outcomes. So this is what happens when surgical innovation sometimes does not follow the recommended pathway in terms of adoption. And, as we're progressing to randomized trials, and there are, 5 randomized trials currently enrolling still, this is what we want to remind everyone is, please look at the guidelines for safe implementation and follow the recommended training pathway and proctorship, and, high case volume and experience with TATME, as Larry and Marlies know very well, is key. And audits, so either you subject yourself to audits or you participate in a trial. Either way, your data should be closely monitored by a third party. Your videos should be reviewed. Your pathology should be looked at MDT or elsewhere. But this is important to monitor your outcomes. So the big question is, where do we go from here? TATME is still very much alive and well, but at specialized centers, we've mastered TATME, and this is where it needs to be, at specialized centers. And if you are at a specialized center with at least 1 or 2 well-trained TATME surgeons, the results are incredible. What you can offer patients with these low tumors who are desperate to avoid a sphincter resection is this. So for those low tumors, this is where TATME is so important. You really enjoy very low conversion rates, and you can really tackle really difficult cases and still have very consistently excellent quality specimens. I have never had such beautiful specimens since, starting 12, 13 years ago. But I'm monitoring my results very carefully, like everyone else who's really focused and passionate about this approach. So skipping ahead, I just want to show you how we're at expert centers are evolved. I'm sure Larry and Marlies have done the same, but we're starting to use TATME for much more complex cases. You can see here, when the CRM is involved and we're trying to actually save the sphincters, but you can still provide very nice resection. You can literally take the endopelvic fascia with you. You can deepen the depth of your dissection. You can titrate your depth of dissection to try to get a negative margin. We're much more aggressive with extensive like radiation changes. These are patients that are after TNT can be up to 9 months post radiation, so their pelvis is completely frozen, literally frozen. There's unbelievable fibrosis, and these cases are very difficult to do laparoscopic robotic from above. And using a transanal approach, you actually have a better chance of navigating those tissues, navigating those tissue planes, and you have the luxury of having a really nice augmented view of the tissues, and you can actually perform these procedures, and your abdominal surgeons will be so thankful. Here we finally found the prostate after struggling for a while to dissect through a rock of fibrosis. But this is what TATME can do for you in experienced hands. So obviously everybody's asking me, I'm going to skip ahead for the sake of time, but everybody's asking, okay, so what about robotic? Should we train in robotic? Should we train in TATME? Where do we go from here? The big question is, what is your question? Are you focused on your learning curve? Are you focused on, operating on patients who look like this? Are you focused on costs? You have to kind of figure out what you want to achieve. I think, most places have now excellent laparoscopic or robotic surgeons. TATME is really reserved for those really difficult tumors. So it's really important to have the volume and the expertise and be able to combine, a skill set to be able to do these procedures. This is a SAGES presentation we just gave a couple of weeks ago that looked at actually across 8 centers performing TATME. These are centers that are currently enrolling in the TATME trial, but looking at the results over the past 10 years, the most impressive part, you can see a significant portion of our patients were obese, above a BMI of above 30, a third of our cohort with really quite excellent outcomes compared to the non-obese patients. So conversion rate was 5.6%, CRM positive rate 5.1%, really reassuring results, again, showing that even in the most complex cases, low tumors, 6 centimeters or less from the anal verge, with BMI higher than 30, we can still achieve excellent quality surgery. Thanks to this approach, which really is a game changer. And we have a small trial here, but I think the big question will be, can you go that low with the robot without converting? The ROLAR trial said no, but maybe now with more experience, the answer is yes. So I'd be really interested to see if we can organize maybe it will not be randomized because you cannot randomize because surgeons really are trained in one or the other. So randomization has no equipoise. But really comparing Transanal to robotic surgeons to see for those really low tumors in a high BMI patients, what is the preferred, best, or safest or most effective approach to be able to perform a sphincter preserving procedure. So we're doing a small pilot right now to look at that. So sur ce, I will pause here, and I would love to hear your thoughts. Thank you.
Well, thank you, Dr. Sylla. I wanted to express my gratitude for this outstanding talk, and also to Dr. Labow. for his immense generosity in enabling us to invite you. So I wanted to just moderate a few comments in the chat from Dr. Vasiliou. She says, such inspirational and pioneering work. Thank you so much, Pat, for setting such a high standard for innovation and introducing new procedures. Thank you also for sharing your work with us today and with the world. So I think, we all feel exactly the same way, and she summarized this very well. Dr. Lieberman comments on understanding anatomy in new procedures is really key. Proctoring and working as a team is critical too, but how do we keep going in pushing the uptake of new procedures such as TATME when the learning curve numbers are so high?
Yeah, that's the biggest challenge. I mean, Larry, I'd love to hear your thoughts, but, I tell the fellows, they all come and say, how do I get there? And I say, well, at the very least, besides, beyond your fellowship year, if you're really serious about TATME, you should really consider doing a proctorship for at least a couple of months at a TATME site. Some of the most successful pathway has been either you go to a place that has obviously a high volume of TATME, or you do a second fellowship, or at least a 6 months proctorship, where you can really hone in on those skill set. And I think in Europe, that's exactly the model they're following. There's just no way to shorten that learning curve, I'm afraid. People are talking now about, simulation, and maybe at some point we'll have some type of model that can help, replace some of that hands-on training, but that's going to be a challenge.
Larry, I'd invite you, Dr. Lee, to unmute yourself and ask your question, and perhaps
Okay.
with your comments.
Yeah, thanks, Pat. That was a great, nice review, kind of showing from the get-go. I think a lot of people here kind of seem a little bit nonchalant when we talk about TAT because we've been doing it like pretty often here now. I think we're at like 70 odd cases, something that we've done here since in the last 5 years since I've been back. But, so like, I agree with you. It's like, it's really hard to know what's the best way to do the, to kind of gain expertise. Like I went to I went to one of the probably few fellowships in the US that did like a super high volume of TATMEs. And even in my year when I went, I did about 20, I saw or did about 25 only. And that was probably already kind of in the like highest volume for fellows going out. And, when I started, we did every case as 2 team. In every case we did kind of with multiple staff doing the bottom part together. And it really took like a long, long time before we got, I don't really know if there's a good answer to how to make this better, because it is hard. It's the truth of it is that it's like the planes are different, the retraction is different, the technical aspects are different. And, like when in Florida, when we were doing the training course, which I have my own opinions on, a lot of people, you watch them kind of operate and you're like, you should not be doing this.
Exactly. Scary.
And yeah, and one of the issues is that like, and it's kind of like the way Intuitive has done it is that a lot of times these training courses are given by the companies that have a vested interest in selling you the stuff. So this was done, and again, I won't kind of name the company so I won't get in trouble, but like it's a bit of an issue when the company is training you to do it. And I don't know if there's a lot of data, like even us, we made kind of like hard models, we've made like virtual models, we've done planes. And when we even asked experts looking at, try to get a consensus with like kind of operative planes, there was like a huge amount of variability in terms of like where people thought the right planes were on video and TME dissection. So I don't really know there's a good answer short of like, you just got to do a million of them.
Yep.
And probably it should not just be done by everyone. I think that's just the end result. The end. And
you can't be afraid to say it.
Yeah, well, as a fellow, you can't tell like, a staff from
that story. So, I think my biggest struggle, to be honest, was, and I love Antonio Lacey, but Antonio went out and starting to tell the world it's the easiest.
People should do this. Yeah.
And everybody should do this. And it was really hard to walk it back, so some of the messaging also by our leaders is so important. And to be humble and is important. And so I think that messaging hurt because people felt I can take a course online and then go ahead and do this. And that really set us back. We had to walk it very carefully after that.
Yeah, so I'm not really surprised by some of the data that because it's not easy. My question for you, Pat, is, I mean, you kind of touched upon it towards the end, was just like, so and a lot of people starting out will use like the really easy cases, right? The quote unquote ones that don't necessarily need to have a TATME approach to get done. And even then in those patients, they have a lot of complications. So again, like how do you kind of justify saying like you should do it if there's a better approach? And then my last kind of comment is just like, for us, we've evolved where we also did that. We did a lot of the easier cases at first, but now we've evolved a bit to now we only do it on the super hard cases, the ones that are like kind of impossible from the abdominal approach. And when we compare our data, when we look at our own data and let's say we compare it to, let's say other centers that may not do quote unquote easier tumors, it's not so comparable. And I would bet that a lot of quote unquote expert centers around the world are also just reserving this for like super hard cases. So how do you kind of interpret that data, right? So coming from the outside, from all over the place, being some are good, some are bad, but these like not, you're almost comparing like apples to oranges in a lot of cases.
Well, and that's where the registry I was hoping would be helpful to tease that out.
But it wasn't though. That was the problem, right? It was useless. Yeah,
it's completely useless. But I think it's at least you're right. I mean, even our phase 2. It's looking more and more. I let surgeons essentially enroll all the way up to, for tumors up to 10 centimeters. Turns out that the majority of the tumors are less than 6 centimeters. So it's self, you know what I mean? It's kind of nice as a phase 2 because you're seeing live what's happening and how the surgeons are selecting their patients. But in the end, it's evolving exactly how you're describing. It's evolving towards those lower tumors that are much more difficult, especially with the robot. I don't know how much robotics you do over here, but there you go. But the rest of the world, reality check is really moving very heavily towards robotics.
Yeah.
And so you're seeing surgeons, and I've observed, even junior surgeons really curious to see if the learning curve could be shorter. And I've been impressed. I mean, they're learning. The learning curve is getting there, and people are really getting very comfortable with robotic low anterior resection. So I think they probably can tackle lesions, up to 6 centimeters, and then that's when things get really tough. So I think that's what the data is really going to show. It's going to be, it really shines, and it's being increasingly used now for those low difficult tumors. And it's hard because then it makes the training even more complex. How do you start from there? I have a problem now doing TATME for a lesion that's, higher than 7 centimeters because I don't want to have to do the double purse string. I really don't.
Yeah, we just don't do it anymore.
Yeah, it should be hands-on.
Yeah.
This purse string, every complication I've had, like the really serious leaks, has been in the setting of that purse string. And it's tough because you can't see the back end of your needle. You don't know the other side. And I don't like that feeling. And so it's pretty much almost all my patients are the ones that are so low that you end up doing a hands-on without sacrificing rectum. So I think that's where the data is looking. The trial will show that trend, even though I'm giving them room to do more, easier cases, but it's not where they're being selected, even on a phase 2 trial. I don't know if that answers your question, but I think it's going to be reserved for those cases like you. I'm sure you see my biggest impact at my institution has been my surgical oncologists are still doing very active with rectal cancer. They call me now. Sometimes they call me from the OR, which is kind of scary. It's like, I can't get there. Can you help me? And that's really satisfying because it's like they're starting to think. And so obviously you like to be able to identify those patients before the OR, and at MDT you should, and combine forces so that you can actually work with your general surgeons during still, these cancers, or the surgical oncologists to provide additional help with these really, really tough tumors.
Paula, you're muted, but
Great.
thanks, Pat.
Oh,
There's not really an answer. There's not really an
Thank
answer to
you.
my question, but anyway.
I'm sorry, but it's, this is, and you're criticizing the data now, but wait until you see the randomized trial, because I don't know how you randomize those patients now. I mean, the premise of the randomized trial already was iffy, if not. And then if you've talked to those guys, they will tell you they have had a really tough time enrolling. I mean, now the only reason they're enrolling on the Collar 3 trial is because they're inviting Chinese surgeons to do it, who are do everything with TATME. So the data will be completely skewed, but surgeons now are pretty much, the ones who are doing TATME are not willing to do those low tumors using a robot or lap. Certainly not lap, for sure. So this is a wrong trial now. You should be actually robot versus TATME, not lap versus TATME for those low tumors. We know it.
Well, I think that, we've gone a little bit over, but we've had a great discussion. And I think if there are any more questions, I'd invite one more, or if not, then I want to thank you again. Thanks so much for joining us today. I'm really sorry we couldn't do it in person, but it was a wonderful talk, and even I, have gained like a new, I think, appreciation, of how TATMEs overcome dissection in the bony pelvis, and I was also very sort of impressed with how you had tackled and sort of dealt with your own complications in a very sort of thoughtful way and methodical, as well as terms of practicing this new procedure responsibly. So thank you so much.
Thank you.
It's been a great example for our residents. Thank you as well.
I really appreciate it, guys. Thank you so much. And thank you again to Dr. Labow for the opportunity to present to this group. It's really quite an honor.
Thank you. Have a great day, guys. We'll see you next week.
Bye, guys.